Okay, Chapter 22, Drug Therapy for Tuberculosis or TB and MAC or Mycobacterium avium complex disease. Learning objectives. We're going to learn about the etiology, pathophysiology of tuberculosis. So we should be able to describe it, at least in brief. We're going to describe the characteristics of latent, active, and drug-resistant tuberculosis, the drug therapy, and the rationale for it, action, uses, adverse effects, contraindications, and nursing implications of the first line anti-tubercular drugs. And we're also going to talk about the second line anti-tubercular drugs, okay? How those are added to the drug regimens and also how they're used to treat the multi-drug resistant tuberculosis. Then we're going to move into MAC or Mycobacterium avium complex and talk about the pharmacology for it or the pharmacotherapy. And we're going to discuss ways to increase the adherence to anti-tubercular drug therapy. Also, we're going to understand how to implement the nursing process in caring for patients who are receiving drug therapy for TB. Okay, so key terms. We only have these five. Directly observed therapy, and that's when the medication is given to the patient by either a nurse or a responsible adult if it's outpatient. And the purpose is to make sure that the patient takes the medication. Extensively drug-resistant tuberculosis, that one actually comes after the multi-drug resistant tuberculosis, which is actually resistant to at least one first-line anti-tubercular drug and at least isoniazid and rifampin. And then the extensively drug-resistant tuberculosis, it's rare, but it's going to be resistant to isoniazid, to rifampin, plus any fluoroquinolone, and at least one of the three injectable second-line drugs. So we're talking already about 4 drugs. Then we are going to talk about hepatitis, which is an inflammation of the liver, and is usually caused by an infectious agent, toxin, or drug. Jaundice, yellow discoloration of the skin and body tissues and fluids. And this is going to be the result of abnormal high levels of bilirubin in the blood, common symptom when drugs cause liver damage. Okay, so tuberculosis, let's talk about this infection in brief. It's going to affect usually the lungs, but it could also affect or involve other areas such as the lymph nodes, the pleura, the bones, the joints, the kidneys, and the GI tract. This is a pathogenic bacilli. This is this is an infection that's going to actually be slow. It's going to multiply slowly, and it can stay dormant for many years. So after the person has been exposed to the M. tuberculosis, which is the bacteria causing TB, it could cause an active infection, but sometimes it couldn't. It could just be there for years. Now, this infection could actually resist the phagocytosis. Remember, phagocytosis, it's a way of our own immune system engulfing certain organisms in order to destroy them and get rid of them. And these pathogen can also develop drug resistance. So there is a few phases of tuberculosis infection, and we're going to talk about them right now. This medication commonly occurs in this infection commonly occurs in many parts of the world. And it affects about 1/3 of the world's population. Okay, That's about 2 million people dying annually because of tuberculosis. Here in the United States, the infection is decreased to low level. Most new cases occur in foreign-born immigrants and large numbers with inactive latent infection. So when we talk about inactive or latent, it's that the bacteria is not active, although it's still alive in the body, and it can become active later, just dormant, just there waiting for its opportunity. Some of the contributing factors is increased exposure during the disease resurgence in 1985 to 1992, immigration from countries where disease is common, such as Mexico, Philippines, Vietnam, India, China, and increasing immunosuppression. Now, there are four phases of this infection. The first one is transmission, and this is when an uninfected person inhales infected airborne droplets that are exhaled from an infected person. So then we have primary infection, and that's when the person actually becomes infected. If the initial infection could happen 2 to 10 weeks after exposure, if it happens, and it's going to show symptoms of like pneumonia-like illness. Many times it is undiagnosed, but some of the other manifestations could be night sweats, cough, and then we have the latent tuberculosis, it's LTBI, and that one is when our immune system is actually able to stop the bacterial growth and the bacteria becomes inactive, but it's still alive in the body. And as mentioned before, it can become active later. And then we have active tuberculosis, and that's when the disease is actually showing symptoms, right? It could happen right away during the first infection, or it could be later reactivated when our immune system becomes weak. Now, drug-resistant tuberculosis, and of course it is a concern to public health because now we have these disease that affects mainly a third of the world, and it could become resistant to drugs. It has actually become resistant to drugs. So it could be because of mutations or biological adaptation of the bacteria, okay? And other factors could be poor patient compliance. We have discussed this before, that many times when we're not compliant with a medication therapy, then our body or mainly those bacteria start developing resistance. Also, we have the development of new strains within patients who are immunocompromised. So we can think of HIV patients, which their immune system is compromised, diabetes, cancer patients, and these scenarios can lay base for new infections, right? Like new strains of these infection. And then we also have the multi-drug resistant tuberculosis. This is when it is resistant to most effective medications available. And then we have the extensively drug-resistant tuberculosis, and this one is even resistant to the second-line medications, and there is no effective drugs for treatment. So that is very sad because tuberculosis could be lethal. And when there is nothing else to treat it, I cannot think of anything else that could help. These type of drug resistant is mainly found in Africa and Asia, and there is a major concern for those with HIV. Okay, so the factors that can contribute to the development, it's again delayed diagnosis, delayed determination of the medication efficacy, and the lack of adequate diagnostic laboratories. Okay, so let me just touch base a little bit on the efforts that the Center for Disease Control has made along with the ATS and the ITSA. And that's the American Thoracic Society and the Infectious Disease Society of America. And they have expanded their efforts in order to treat latent tuberculosis or in order to prevent the active phase of it. So what is our role as a nurse? Well, mainly it's following the recommendations to prevent transmission. It is our role also to perform and read the TB test or the Mantoux test. We also have responsibility on tracking contacts of those with active disease and also to assess the settings for risk factors and educate about TB infection and treatment. We also may have a role on administering the tuberculosis medications. And that's usually when the patient is inpatient, or also making sure that there is a responsible adult to administer to help administer the medications, and that's by witnessing that the patient is taking the meds. Now, why are we so strict with this, and why do we put so much effort? Because tuberculosis, guys, is very contagious. It can't just spread, and as we said, mentioned before, it is through contaminated droplets. Okay, so we need to make sure that we do our best, do our part to prevent the disease, and also by screening we identify those potential cases, right? If a patient has latent TB, then we want to treat it before it becomes active. So now let's talk a little bit about the development of the extensive drug resistant to tuberculosis. And many times it's because either it wasn't diagnosed on time, there was no prevention, and also there was a failure to treat for the multi-drug resistance. Remember that the extensive resistance it's a level up from the multi-drug resistance. So the drug resistance, guys, is not suspected until 2 months of ineffective drug therapy. So we're not going to know until 2 months after. And also the delay, this delay, it's going to actually lead for a higher risk of transmission. That's why patients who have either latent or the active cases of tuberculosis need to be identified. And then there is a questionnaire, right? Like we question, like, okay, who do you live with? And all of that, they're networking, because that's how it spreads. And we're seeing it now with COVID, guys, how if a person gets a positive right away, they need to ask them, okay, who were you in contact with? Who do you live with? They put the entire household on quarantine, and then they start inquiring, because the whole point is containment. Now, the needs to prevent or to control or limit this disease is better internationally standardized test for susceptibility testing of second-line medications. And so that's something that we need to develop, right? Having a better outcome, as not only as a nation, not only here in the US, but also internationally. We are at the border with Canada and Mexico, and we need to make sure that better standards are developed among the nations, and also new anti-TB medications and drug therapy regimens. and also having better diagnostics for TB and for the multi-drug resistance TB. Okay, so now let me touch base a little bit on the MON2 test or MON2 test. And this is mainly an intradermal injection of 5 units of purified derived protein from the M. tuberculosis. So the way we read it is if there is 5 millimeters of induration, and induration is the bottom picture, and that it gives you the 3 stages of induration. If 5 millimeters are present, then it is considered positive when the patient is immunocompromised. So we're thinking patients with HIV or any other condition that compromises the immune system, as well as recent exposure, regardless if they're immunocompromised or not. If they had recent exposure and the induration is 5 millimeters or more, then it is considered positive. Now, if the induration is 10 millimeters or more, and they're immigrants, drug users, injectable drug users, long-term facility residents like prisoners or nursing home patients who are in long-term either care facilities or a prison, then it is considered positive. Lab personnel, especially those for mycobacterium labs, those that are mainly dealing with any type of mycobacterium, such as tuberculosis. Also, high-risk clinical workers, that includes all of us, right? Like either we work as nurses or lab assistants or nursing assistant or medical assistants. If we work at a high-risk facility such as clinics, hospitals, then and we have an induration of 10 millimeters or more, then we're positive. And also patients that are less than 4 years of age. Now, for the rest of the population, any person regardless of the risk, this includes everyone else, it's 15 millimeters or more for the induration. Now, the anti-tubercular medications, or the medications to treat tuberculosis, we have the first line agents, or the primary agents, in order to treat the latent, active and drug-resistant TB when possible. Now, for latent TB, remember, that's not the one that's active. It can be dormant for years. We use the isoniazid, or INH, and the rifampin, or RIF. And then the third one is rifapentin. Now for active, for the treatment of active TB, then we still use the isoniazid, the rifampin, and then we can add ethambutol and pyrazinamide. Okay, so for second line medication, this is when patients are not able to tolerate the first line drugs. This is the alternate, or when there is a resistance already for the first line drugs, then the second line medications come into play, and those are some aminoglycosides such as amikacin, caprimycin, and kanamycin, and also streptomycin. And then we have medications such as cycloserine, ethionamide, and the paraminosalicylate acid. Also, some of the fluoroquinolones can be utilized as second-line medications, such as moxifloxacin and levofloxacin. Now, for active tuberculosis treatment, we mentioned before we could use the isoniazid, which is the INH, or the rifampin, or RIF. And when the therapeutic effects are actually seen is within 2 to 3 weeks. We're going to see decreased fever and cough. Patients are going to gain weight, because with tuberculosis, there is a weight loss when it's active, and then they're just going to feel better. and the treatment will continue for at least 6 months. Now, it could also continue 3 months after the cultures have become negative. Okay, guys, so sputum cultures are usually negative within 3 to 6 months. If the patient is symptomatic or has a positive culture after 3 months, we start wondering, is the patient non-compliant? Is there a drug-resistant organism? So alternate therapy may be indicated. Now, for this lecture, we're going to focus on the first line anti-TB drugs, as well as the second line, the ones that can come into place when the first line cannot be used or is already resistant. So remember, INH or isoniazid, RIF or rifampin, other rifamycins, ethambutol, and pyrazinamide. So there is also some new anti-tuberculosis drugs, and that includes the bedaquiline. That one has FDA approval, guys. Now we have delaminid, and that one is not approved by the FDA yet, only in Europe. So those are the most recent drugs to treat tuberculosis. There is a table, guys, with all of the medications for tuberculosis, and that's table 22.2, and how is that they should be used. As you notice, the treatment is extensive. We're talking about 3 to 6 months at least. I would say 6 months, since the sputum cultures are probably negative within 3 months, and then they still have to have therapy for 3 months more after the culture is negative. So we're looking at least 6 months of medications, okay? Now, we also have some combinations for the medications. So I'm going to ask you to please pay attention to those. Your book is listing the ones that are combined. And also, guys, it is important that we are aware of the patient teaching guidelines for these medications. For example, for isoniazid, we need to make sure that patients do stick to the medication regime. It is important, it is essential that they finish their medications. They should be feeling better within 2 to 3 weeks. If not, they need to notify the doctor. Okay? Now, when they take INH daily, the isoniazid, they need to also take vitamin B6 at the same time. So that's going to help them not forget about taking the vitamin B6. And if you read your book, you'll see why. It does mess up with vitamin 6. So if it's possible, take it on an empty stomach, no alcohol while taking this medication, since this medication can cause liver damage. If they start experiencing numbness, burning, tingling of the arms, the legs, they need to notify the doctor right away. As those are symptoms of adverse effects. And then we're going to have liver function testing. That's blood testing, okay? So it is important that they keep their appointments. So talking about directly observed therapy, guys, and I had already mentioned this is when an adult or another responsible adult or a healthcare provider it's observing the patient ingesting the medications. And this is recommended to make sure that patients adhere to the medication therapy. It is considered mandatory when intermittent dosing is utilized, and that's when, for example, a patient, instead of taking 5 milligrams daily, then the doses are combined so that they can take the medication only 2 to 3 times a week. Okay, it is considered, directly observed therapy is considered mandatory for when patients have the multi-drug resistant tuberculosis. I also want you guys to take a look at table 22.5, and it's talking about adjuvant first-line antitubercular drugs, okay? And remember, that's when more than one drug is combined to help with the disease or the illness. And also pay attention to the first line drug combinations and the second line drugs that are used to treat tuberculosis. In the first line drug combinations, review INH with RIF, that's your isoniazid, along with the rifampin. They're combined, and this is going to help also give less tablets to the patients. We also have the INH with the RIF and pyrazinamide, and that's combining 3 medications into 1 tablet. And this is going to increase convenience for the patient. It's going to help the patient adhere to the prescribed drug therapy. And also, please review the second line drugs used to treat tuberculosis. Okay, so let's talk briefly about Mycobacterium avium complex. These is 2 different types of very similar pathogenic mycobacteria, the intracellular and avium mycobacteria. It is mainly found in water and soil through the United States, and it is transmitted by inhalation of infected water droplets. There is no evidence of human to human or human to animal spread. It is rarely going to cause disease in immunocompetent people, but it's not the same story in immunocompromised as people, for example, with HIV could get it. And think about our immunocompromised patients and how any opportunistic pathogen can actually cause a serious infection on them. These type of complex or disease will show similar manifestations and symptoms as tuberculosis. So the cough, the fever, the night sweats, the malaise, the fatigue. And the treatment for these is azithromycin, clarithromycin, ethambutol, and rifabutin. Now, there's other medications that could be used, such as the amikacin, fluoroquinolones, and streptomycin. Now, I would like to mention that actually rifabutin interacts with clarithromycin, and it's going to decrease the clarithromycin levels. So I don't think those are 2 medications there. It's a good idea to mix. And when patients are very immunocompromised, then rifabutin or a fluoroquinolone, such as levofloxacin or monofloxacin, can be used as a 3rd drug. Now, the goals of therapy, guys, as with anything else, is bring our patients to a better level, right? We are expecting for those therapeutic effects to show, and in this case, actually cure latent or active infection. Also, the goal is to avoid the development of drug resistance to tuberculosis, to minimize the transmission of TB to others, right? That's why we screen, that's why we interview, we ask, we inquire about who do they live with, their whereabouts and everything, so that we can try to catch as many infected people as possible in order to treat them and help them. Active infection, decreased signs and symptoms. We want to make the patient non-infectious, and we want to ensure that the patient is taking the medication. Now, I would like to mention, guys, that here in El Paso, we actually have a TB clinic, and I was reading in the city's website, and the 3 main medications that are given here in El Paso, it's the isoniazid or INH, the rifampin or RIF, and then the other one is the rifapentin or RPT. Now, the general guidelines for TB drug therapy. We know that multiple drugs are required for effective treatment. Many times they're going to come combined. The duration of the therapy is specific to the purpose, the extent of the disease, adherence to the drug therapy, regimen and the clinical response. Remember that if the patient has no symptoms at all, gets a negative culture, treatment's still going to be given for 3 more months at least. Now, the multiple drug-resistant tuberculosis can happen anywhere. In the United States, it is most evident in those with AIDS and also people in closed environments, such as facilities. We have already talked about prisons or maybe nursing homes and in large urban areas. Now, the treatment for the multi-drug resistant tuberculosis is going to require the use of more than one medication, right? Maybe a longer period of drug therapy, daily administration, and the DOT, right? The drug observed therapy. Now, the treatment is extremely expensive for the multi-drug resistant tuberculosis, and the extensively drug resistant tuberculosis is extremely limited because of the extensive resistance to primary and the second line medications. Now, how to increase adherence? Well, we already talked about the DOT, right? The drug observing therapy, the intermittent drug administration, where the doses are combined in order to give them in less frequency than a daily dose, patient education and family members education, get to inquire about the contacts for the infected patient, and so that treatment can be provided to more than just them, right? Now, think about it. If there is not enough information about the contacts for a patient who's been infected, then other infected people could be around in the community, spreading out tuberculosis. And since many times, only I think 5 to 10% of people would probably show symptoms after being infected, then many times it's going to be latent and just dormant until it finds the opportunity to come up. Now, another ways to increase adherence could be individualized treatment regimens and also promote communication and continuity of care. Now, monitoring anti-tuberculosis therapy, clinical monitoring, it is indicated for all patients, education, right? Signs and symptoms of adverse effects, and a regular assessment by the healthcare provider. Assess for signs of liver disease, as we have mentioned before. Some of these medications can be very hard to the liver. Now, the laboratory monitoring, we need baselines. And we're going to need the liver enzyme levels. Also, for patients who are immunocompromised, like especially those with HIV, we need a laboratory monitoring for pregnancy, for early postpartum, and for patients who have alcohol abuse. For the liver enzymes, guys, those are the ALT and the AST. Now, for the use in special populations, patients with which are HIV positives or any other immunocompromised patient, right? Children, older adults, renal impairment, hepatic impairment, and home care. Make sure that you check those out in your book and add to your drug cards as necessary.